Shott at Cincinnati Children's Hospital, and we're going to talk today about Down syndrome and some of the otolaryngologic manifestations. Just a little background. So the incidence of Down syndrome is 1 in 800 live births. 75% of fetuses with Down syndrome usually spontaneously abort, and it occurs in all cultures, all ethnic groups, all geographic areas. The risk of having a child with Down syndrome does increase as the maternal age increases, but most women having babies are young. So actually 80% of babies are born to women less than 35 years of age. There's about a 1% recurrence rate. It was originally described by John Langdon Down in 1866, and that's where Down syndrome came from. The chromosomal basis of the syndrome, however, wasn't described until 1959 by Lejeune. Initially, there was, because of the Down syndrome facies, originally it was assumed there was some sort of racial ethnology, and that's the term Mongolism came from, and we don't use that term anymore. I would stress that when you refer to a patient who has Down syndrome, refer to the patient first and to the child first, that your child with Down syndrome, not the Down syndrome child. Parents are very attuned to that, and if they hear you referring to their child appropriately, they immediately bond with you, and if you don't do it correctly, they get upset. In the earliest 20th century, patients with Down syndrome were the largest population of institutionalized patients. So in the old days, very few tests were done. Everything was just, oh, this is part of Down syndrome, and there was really no interventions. And life expectancy was only 9 years of age. And as I said, people with Down syndrome were the largest percentage of people with disability who were institutionalized. And I have to tell you, it's been totally parent-driven, these changes. The parents wanted better care for their children. It wasn't doctor-driven. It was parents pushing the doctors. And then in 1984, there was a law passed called the Baby Doe Law, and it really came from care not being provided to a child with Down syndrome. And this said that all disabled infants must receive full care, except if they were in irreversible coma, treatment would prolong dying, or the treatment was futile or inhumane. And that has changed everything with Down syndrome, because 50% of children with Down syndrome have a cardiac anomaly. So the life expectancy is now 60 years of age as that cardiac anomaly has been repaired. Children are not institutionalized, they're part of their family. There are currently 50 families on a waiting list hoping to adopt a child with Down syndrome. There's a very strong Down syndrome adoption agency. The level of development delay has found to be very variable. Much more inclusive education, and at various degrees depending on the child. And in addition, people with Down syndrome are better accepted by others with disabilities. And I will tell you, families have very high goals. They want the best for their child. Before we talk about the ENT problems, I wanted to bring up a couple other medical problems because it will affect your care. So as I said, 40 to 50% of people with Down syndrome have a cardiac anomaly. And you need to understand that abnormality and how it may affect your surgery. All children with Down syndrome have a cardiology evaluation echocardiogram at birth. There are quite a few gastrointestinal problems, and I think the one that affects us the most is gastroesophageal reflux. And as you know, there's always been a lot of overlap between GER and or GERD and ENT problems. So 77 to 80% of newborns with Down syndrome have or will develop some type of GI abnormality. And this contributes to problems with swallowing, food rejection, failure to thrive. Feeding difficulties account for 20% of admissions for newborns with Down syndrome. And that reflux will cause swelling of the posterior pharyngeal wall and upper airway, which will decrease the upper airway size, and it's already a smaller airway size. So breathing sounds will sound very wet and congested. Unfortunately, GERD can be difficult to diagnose, but what I do in the office is I always give a good exam at the back of the throat, the soft palate, You can do a flexible laryngoscopy in the office, and if you see all this swelling, I think it's reasonable to try one of the anti-reflux medications. And I then recheck the babies in a month, and I would say the far majority of them have totally different exam a month later if they're on reflux medications. But if I don't see any improvement, that's when I will refer to GI for possibly an upper endoscopy to rule out celiac disease or eosinophilic esophagitis. But the high majority of this is really just reflux. Now, another problem that we see a lot in Down syndrome is pharyngeal dysphasia. And these are swallowing problems associated with aspiration where, obviously food or liquids go into your windpipe instead of your esophagus. It can be associated with coughing with feeds, but a lot of the patients with Down syndrome will have silent aspiration where they don't cough at all. They don't have any reaction to the food going down into the trachea. Now, some of that is because the reflux actually decreases sensation of the pharyngeal tissues. So they don't feel it going down the wrong spot. And there've been a couple really good studies by speech pathologists looking at this, showing actually as high as 60% incidence. Now, in most children that have aspiration, it usually resolves by age 2 to 3. But in children with Down syndrome, they found that at age 7, 80% continued to have this problem. So it is something you have to follow long term. If you do see a child who's having aspiration, you need to rule out an anatomic reason for this. So first of all, you need to look and see if the vocal cords are moving correctly. And then also you need to rule out a laryngeal cleft. Usually we can treat this with thickened liquids. I think you should consider pharyngeal dysphagia if oxygen levels are lower than you expect and you can't explain that. There's no current recommendations, however, in terms of the Down syndrome guidelines for testing for it, but it is diagnosed with a video swallow study. Another problem we see a lot is our pulmonary problems and hypoxemia. Now, there's a couple reasons that children with Down syndrome have a higher incidence hypoxemia. There's more pulmonary infections because their immune system develops slower. You have hyperventilation due to decreased muscle tone. And then the other thing that was just discovered in the last few years, there's actually impaired development of the alveoli and pulmonary vasculature. So can you see the arrow? So alveolar simplification is where you have failure of alveolar septation leading to simplification of the alveoli. And basically you have these little cysts at the periphery of the lungs where alveoli have not formed. So it's decreasing the overall surface area for gas exchange. And this is something commonly seen in Down syndrome. It's picked up usually with a CAT scan of the lungs. Thyroid problems, hypothyroidism is more common, though some have hyper, but about 50% of adults with Down syndrome will have hypothyroidism. Again, you need to know that because that can affect anesthesia if you're doing any type of surgical procedures. All right, so let's look at the ENT problems. Just a little bit of history. When I first went into practice, which was like 32 years ago, I started seeing a lot of children with Down syndrome, so I had never been taught anything about Down syndrome and was reading about it, and everything was sort of retrospective and descriptive, no intervention. Here's a paper, we examined 20 children with Down syndrome, and this is what we found. But nobody did anything. So a lot of the studies just relied on parental reports to determine outcomes. There was no objective data and very few evidence-based recommendations. And it was really, as I said, parents were much more, were the people who really drove the need for change. They wanted to know what they could do to improve their child's life. And the parents really wanted more from their physicians. And I hate to say it, but you still sometimes, I will see a patient that comes from usually another city, and they've moved to Cincinnati, and I'll ask them what type of care they had before, and they'll say, well, our doctor said we don't do anything, it's just part of Down syndrome. And they were very negative about any chances of improvement in my child. So we still see that. One of the most common things we see is chronic ear disease. Now, why do we see that? Well, there are some anatomic anomalies of the eustachian tube. It's shaped differently. There's decreased function of the muscles of the soft palate that open and close the eustachian tube, as well as decreased cartilage cell density, so the eustachian tube collapses more easily. Remember that people with Down syndrome have they have significant contracture and hypoplasia of the midface. So because of that, the whole midface is smaller, so your nasopharynx is contracted, and the eustachian tube more easily will get blocked. And then that reflux comes back again. Studies have shown actual pepsin in middle ear fluid. There's an overall immaturity of the immune system. So it takes longer for the immune system to develop in children with Down syndrome. And that's a lot of reasons why you will see the first few years where there's a lot of viral infections and that chronic runny nose. And it's really due to more upper respiratory infections because of this immaturity of the immune system. So that's going to secondarily lead to the chronic ear infections. The other thing we see is 50% of babies with Down syndrome have very small stenotic ear canals. So it makes diagnosis of otitis media difficult, that if you can't see it, you really can't diagnose it. And you'll get hearing loss from ear canal collapse and also from just wax impactions. So what do we know? We know that chronic ear infections are more common, 3 times higher incidence of chronic otitis media and secondary hearing loss compared to other children. We know that the infections last longer, or children with Down syndrome take longer to, quote, grow out, unquote, of their chronic otitis media, which means it takes longer for the eustachian tube to start functioning better. Our studies have shown that 30 to 40% will continue to have chronic ear infections over age 6. Multiple sets of PE tubes are frequently needed. And also, if you have a perforation in your eardrum, it's better to wait until these children are older. Usually we talk in terms of repairing a tympanic membrane perforation between 6 and 8 years of age. I usually wait until older teenagers before I do it. We know that there's a higher incidence of inner ear abnormalities. So this was a study done in Toronto where they looked at, I think, 100 CAT scans. And they found that there were statistically significant differences in 55% of the inner ear measurements that were done in people with Down syndrome compared to typical children. Now, the problem with this study is they didn't correlate it with the hearing levels. So just because you have a slight inner ear abnormality, they really did not talk in terms of what were the hearing levels associated with this. So previous published studies on the incidence of hearing loss were always like 40 to 75% incidence. And the question was, is this the true incidence? And a lot of us who have taken care of children with Down syndrome really had this hypothesis that the incidence of hearing loss was due to consequences of poor medical surveillance and lack of aggressive medical and surgical intervention of the chronic otitis media. And if we were more diligent and provided more aggressive care of the chronic ear disease, we would have better hearing levels. And in terms of what does that mean? What's more aggressive? You really should see the children every 6 months. If the ear canals are really small, I check the ears every 3 months because you don't want to miss an asymptomatic effusion. I let the referring pediatrician or physician know that this child has really small ear canals, and I know you can't see them, and I really have to do an exam in the office with a microscope. They actually make very specifically small ear speculum that you need to get in order to examine the ears under the microscope in your office. Audiograms should be done every 6 months until you're able to get ear-specific testing, meaning you can test the right and left ear separately, and then appropriate medical and surgical intervention of the otitis media. So we have found that children with Down syndrome who have tubes in place actually have a 3.6 times higher chance of having normal hearing compared to audiograms when the PE tubes were not in. We have also found that the incidence of hearing loss is actually much lower. It's not 75%. If you treat the chronic otitis media, The hearing loss incidence is more 20 to 25%. And these children may have a nerve hearing loss or sometimes a conductive hearing loss that can't be explained by the chronic ear infections. We did a recent study where we looked at a group of children that we had been following for many years. And at age 16, 83% had functional hearing at age 16. So that's pretty good. Now, on the other hand, we have also found that there is delayed onset of hearing loss with worsening of hearing in late teen years or older. And this is called early onset presbycusis. So suddenly you've been following some patient and they're like 17, 18, 25, and all of a sudden their hearing drops out. We don't really understand why that happens, but it's why you really need to continue yearly hearing tests. So the 40-75% incidence is no. It's less common if you do aggressive medical and surgical care, diligent examination with microscope in your office, frequent follow-up exams, early PE tube placement, and also prepare the parents that PE tube replacement will most likely be needed. The other thing is, I think it's important to educate your parents that if the eardrums cannot be seen by the pediatrician, they need a referral to an ENT doctor. And if the ear canals are really small, that they should expect an exam every 3 months under the microscope. And if they go to an ENT doctor who says, I can't see, and they don't use a microscope, you probably need a new ENT doctor. In terms of medical treatment of otitis media, it's the same as everybody else. Antibiotics, consider reflux medication if you're seeing a lot of edema in the posterior oral pharynx. You need to eliminate risk factors. And I really talk to the parents about this. You know, daycare studies have shown that daycare is a risk factor for chronic otitis media, but if you can get in a daycare where there's only 6 to 8 children in the group, a lot of the risk factor goes down. And particularly cigarette smoke needs to be eliminated, any type of exposure. In terms of surgical treatment, again, PE tubes indications are similar to typical children, but they're sooner. Recurrent ear infections, instead of 4 infections in 6 months, we're going to say 3 in 6 months. Persistent fluid, if you have persistent fluid for really 3 months, we're going to talk about tubes. We're not going to wait the 4 months. And then sometimes you just have a child who comes in with one acute episode that won't improve on multiple courses of antibiotics. In terms of testing, there are actually, the American Academy of Pediatrics actually has guidelines specifically for people with Down syndrome in terms of what type of care they should have throughout their entire life. And in terms of the ENT recommendations, they recommend an ABR by age 3 months, behavioral audiograms every 6 months, and continue testing every 6 months until ear-specific testing is achieved, and then yearly if normal. If there is some hearing loss and chronic ear disease, it may need to be more frequently. In terms of amplification, hearing aids, and cochlear implants, all of these are very successful in children with Down syndrome. A lot of times parents look at me like a hearing aid, one more thing that we have to worry about, but the kids actually accept them very quickly, excuse me, because there's sort of that immediate gratification. They put that hearing aid on and they immediately hear better. Studies have also shown that mild hearing loss can affect people with Down syndrome more than others with other types of disabilities. So you should, even if there's a mild hearing loss, you should try and get the child to wear a hearing aid. All right, we're going to change gears and talk about sleep apnea. So as you know, obstructive sleep apnea are episodes of partial or complete airway obstruction during sleep, usually associated with decrease in oxygen saturation or hypoxemia, and can also be associated with carbon dioxide retention due to hypoventilation with hypercarbia. Unfortunately, there's a much higher probability of developing obstructive sleep apnea in patients with Down syndrome, and frequently it's asymptomatic. This higher risk is due to that mid-phase hypoplasia we had talked about, that very narrow nasopharynx. Everything gets clogged more easily. a large tongue, the muscular hypotonia. Now that large tongue is a relative macroglossia. It's not that the child with Down syndrome's tongue is bigger than the kid next door. It's more that the oral cavity and the whole midface is smaller. In addition, because of the immune problems, there are increased upper airway infections. And then our studies have also shown that the larynx and the trachea are smaller. In addition, there's a higher chance of developing some of the complications of sleep apnea. Now remember, 50% have an underlying cardiac anomaly. So pulmonary hypertension and heart failure is more likely. And then some of those pulmonary anomalies and the hypotonia that we talked about contribute to the hyperventilation and the chronic hypoxemia that could be associated with sleep apnea. So why do we worry about sleep apnea? Well, it affects the whole family. You know, if the child doesn't sleep at night, the rest of the family doesn't sleep. In terms of cognition and IQ, recent studies have shown a 9-point lower verbal IQ score in children with Down syndrome with sleep apnea compared to a similar group of children with Down syndrome who did not have sleep apnea. So that's actually a pretty big number when you already have a fairly low IQ. It contributes to behavior problems and ADHD. There's increased risk of cardiovascular disease, systemic hypertension, pulmonary hypertension. And remember that sleep apnea can also be associated with a higher rate of diabetes and abnormal glucose metabolism. So how do you diagnose it? Well, the gold standard is getting a sleep study or polysomnogram. This just goes, you know, it's very important to make sure that when you have a patient, a pediatric patient that has a sleep study, that they're using that they're using pediatric definitions and not adult definitions. If we look at the incidence of sleep apnea and Down syndrome, there's multiple studies here. The earliest one was in 1991, where Carol Marcus looked, where Carol Marcus looked at 53 children, but it was a very wide range, okay? And they all had abnormal sleep studies. This was a pretty comprehensive study by Chrissy Hybe, where she looked at 209 children and really looked from 3 weeks to 18 years of age. And if you break it down, the overall incidence was 80%, and it was higher if you were less than 4 years of age or if you were older. But still, all of these numbers are very high. If you look at the disease severity, about 75% was mild to moderate, but it was severe in 25%. Now, what about children with Down syndrome who snore? This was a study, I think, out of Australia. And 33 children, they were not obese. They were about 5 years of age. None had undergone an adenotonsillectomy. They all snored, and 97% had sleep apnea with an average obstructive index of 12.9. So that's severe. So remember, anything over 10 in children is severe. What about adults? There aren't a lot of studies in adults, but this was one looking at 16 adults. 94% had sleep apnea, and in most it was moderate to severe. In addition, 75% had oxygen levels below 85%. One of the problems we see is that parents of children with Down syndrome underestimate severity of their child's sleep abnormalities. So when you say to the parent, you know, because usually it's you ask the parents, you know, do you notice any problems sleeping? Are they snoring? Are they obstructing? Are they stopping breathing? Most of the parents, they think it's just normal. They may not hear obvious snoring. They sort of fall into that trap of, well, sure, she's a crazy sleeper, but I just assume this was normal for someone with Down syndrome. Sleeping with your head hyperextended, sleeping in a sitting position or bent forward at the waist, found sleeping, sitting up on the floor, or repeatedly getting up at night. These are all types of symptoms associated with sleep apnea. So who should get a sleep study? I think that if you have a parent who's concerned about obstruction, including poor sleep habits, frequent wakening or unusual sleeping positions, and then the American Academy of Pediatric Guidelines suggest that all children with Down syndrome should have a sleep study by age 4, even if no obvious symptoms. Now, the reason for this was our studies have shown that at age 4, over 60% already have sleep apnea. Now, I think that if there's symptoms earlier than that, you may want to consider earlier than that. But even if there's no symptoms, you should get one by age 4. Sleep studies in children with developmental delays. Now, a lot of times, you know, I see parents, or their parents call me and they say, well, can we do it locally? They don't want to drive to Cincinnati. This is the instance where I say, no, you really need to go to a pediatric sleep lab. It's worth it to drive 2 hours, 4 hours to get to a pediatric center because your success rate is going to be much higher. So for instance, we know that children with developmental delays are going to pull the monitors off. You put them on, you take the monitors off. You need sleep technicians who are very patient. You need to prepare the parents to, you know, that it's not going to be an easy study. It's important that they stay calm. I will tell you that if the sleep tech gets frustrated and angry at the child because they're pulling the monitors off, that parent's going to get up and leave. So I do think it's important to go to a pediatric sleep lab. In addition, then you know they're using the right definitions when they're reading the study. Now, what about treatments? There's a lot of medical treatments that can help upper obstruction. A lot of nasal saline spray, hypertonic saline irrigations. Remember, we talked a lot about that mid-face hypoplasia. The nose, the nasopharynx, everything just gets clogged up. So a volume is the key. So 1 or 2 sprays is not enough. It's more 5 or 6 sprays on each side. It's hard for me to ask a 4-year-old to do, you know, a neti pot, but I think 5 or 6 sprays, you're getting that volume enough to really wash down any secretions, eliminate risk factors, especially cigarettes. You know, think about allergies. You know, kids with Down syndrome get allergies just like anybody else. Steroid nasal sprays or antihistamine sprays, sometimes the anti-leukotrienes. And then there have also been a few studies that suggest that nasal steroid sprays or the anti-leukotrienes actually can be helpful for treating mild sleep apnea. Oxygen. So oxygen during sleep, that is a treatment that we frequently use for the very young children who have sleep apnea. So I'm not about to do a tonsillectomy on a 4-month-old. But if they're having a lot of obstruction during sleep and their sleep study shows significant sleep apnea, we'll do a sleep study with oxygen, an oxygen titration study. You know, as they grow, things will change. And there's multiple studies that have shown that with a lot of children, as they grow, the sleep apnea does improve. And that's just because the overall size of the airway also improves. It is important, though, to monitor for respiratory depression or hyperventilation, because you just can't throw oxygen on a baby. Because a lot of times it's the hypoxemia that drives their respirations, and if you give them oxygen, they're going to start having hyperventilation. Weight loss. So weight loss if the child is obese or has had a recent weight gain, and I find that to be particularly a problem in the preteen years. So it seems like everyone's involved in sports activities when they're younger. Everybody plays on the baseball team. Everybody plays on the basketball team. There's a lot of activity. But as you get into those preteen years, the teams become more specialized. And suddenly kids with developmental delays and those with Down syndrome are being left out. They're not doing as much exercise. We also know that people with Down syndrome need to take in less calories. So it's makes it even harder to lose weight. But their metabolism is slow, so they have to take in less calories, and that's where we tend to see a lot of weight gain, which exacerbates the sleep apnea. Palate expanders. At approximately 8 years of age, the dentists are putting on palate expanders. Now remember, the roof of your mouth is the floor of your nose. So a lot of the kids have very contracted nasopharynxes and high arch palates, and if you can widen the palate, it's going to give an increased nasal airway. There are a bunch of dental appliances that are also used. The problem with the dental, I don't know if I had a picture. Nope, I don't have a picture. The dental appliances have been shown in adults with mild to moderate sleep apnea to be very helpful. The problem is you have to have all your secondary teeth in place. So most kids can't use them till they're about 14 years of age. And then there's continuous positive airway pressure, or CPAP. So CPAP, you know, I always thought there's no way children with Down syndrome will wear CPAP, but actually we get between 50 and 60% positive compliance, okay? It does work. And, you know, I think that a lot of our surgeries that we do for sleep apnea, our success rates are not that high. And the thing is, if you wear the CPAP, it's going to work. And we have found that sometimes you need to try several different masks. We will sometimes admit the child for a couple nights with CPAP training. We also have a sleep psychologist who works with a lot of our kids and working with the parents to get them to wear the CPAP. I have found that you really need the parents to buy into it because they're the driving force in terms of getting that child to wear the CPAP. The difference is, we talked about hearing aids. You put hearing aids on, you immediately hear better, you get it right away. Wow, this hearing aid is great. I can hear TV better. But the CPAP, you don't wake up the next morning immediately feeling better. It takes a while before the kids start to realize, you know, if I put this mask on, I am happier during the day and I have more energy. And we definitely get to that point where the kids go get their mask when it's bedtime. Remember, though, that you do, as opposed to adults where they tend to just do a CPAP titration and they don't follow up with that, every few years you do need to do a repeat evaluation because kids change as they grow. What about surgery? So in the very young children who have laryngomalacia, supraglottoplasty is definitely an option for sleep apnea in infants with Down syndrome. We used to think of laryngomalacia as being a disease only of newborns, but actually it occurs in all children. So this is something you do want to evaluate in all the children. And so supraglottoplasties are a treatment option. The success rate in those with Down syndrome is not as good, I will tell you, as in other children. So you always need to get a post-operative sleep study. Removal of the tonsils and adenoids is the most common treatment for children. And you know, it's because it's TNA, tonsils and adenoids are the most common site of obstruction. It will improve the obstruction, but it's not totally curative. We have, however, found there's about a 50% reduction in the degree of sleep apnea, but 50% will have persistent mild sleep apnea that can be treated medically. So if we have children that have a post-operative sleep study after their TNA and their obstructive index is less than 5, a lot of times we will treat that medically, treat the upper air obstruction, we'll use Flonase, sometimes we use Singular, but 40% will also have moderate to severe that requires more aggressive intervention. So it's very important to get a post-operative sleep study. Now, you know, I will tell you that if I see a child with Down syndrome who has complaints of whose parents report significant obstruction during sleep, sorry, and they have big tonsils and adenoids, I will take their tonsils and adenoids out and I will get a post-operative sleep study as opposed to both. But it's very important to get that post-operative sleep study. So a lot of times parents say, well, why are we getting this post-operative sleep study? Because there's nothing else you can do. Well, actually, there is a lot you can do. But first, you have to figure out where the obstruction is occurring. And, you know, we do see a lot of adenoid regrowth in children with Down syndrome. I think a lot of it is because the adenoids are removed at a very young age because of the obstruction. And also because of that contracted nasopharynx, a little bit of adenoid regrowth will affect them more than a typical child. So they do tend to have much more of that. You can do flexible endoscopy in the office. We do sleep endoscopy in the operating room. And then there's another study called a Sinha Mri. So the DICE, or drug-induced sleep endoscopy, we have a sedation protocol similar to natural sleep. It does require, it's a general anesthesia, but they're still breathing on their own. We try to use medications that don't disrupt natural sleep. And you can look for adenoid regrowth, nasal obstruction, base of tongue obstruction, enlarged lingual tonsils. It also, we can go through the vocal cords and look at the larynx and the trachea, which I think is more important in children who can have trachomalacia more often. You know, here, if you just drop a scope in the office, you can see enlarged lingual tonsils. Much higher incidence of enlarged lingual tonsils in children with Down syndrome compared to others. The other thing is with the sleep endoscopy, we'll see obstruction of multiple levels. Here we're going through the nose, and we get back to the nasopharynx, and you can see there's been significant adenoid regrowth. And now we're at the base of the tongue, and you can see the epiglottis, but look at these enlarged lingual tonsils. Now, if you just stop there, you'd miss this. So here you see that the epiglottis is prolapsing, and there's a significant laryngomalacia. So we actually see 3 different levels of obstruction in this child. The other way to evaluate residual sleep apnea is doing a Sinha Mri, which is a high-resolution dynamic examination of the airway. And basically, they take 128 pictures over 2 minutes, so it comes out like a movie. And we do it when the child is having episodes of snoring or drops in oxygen. We use the same type of sedation that we use for the DICE. We use it, it's particularly useful in those with complex airways because you can see multiple levels of the airway at the same time, so you can more easily identify what's a primary source of obstruction and what may be a secondary source. And this was a study specifically looking at children with Down syndrome who had had previous TNA. And where was the obstruction? Well, macroglossia, big tongue, tongue falling back, recurrent adenoids, enlarged lingual tonsils, and hypopharyngeal collapse. So you can see a lot of it is something easily fixed, okay? Recurrent adenoids, that's easy to fix. Lingual tonsillectomy, that's pretty easy to fix. The glossoptosis, the big tongue, that's a little harder to fix. So here's a Sinha Mri, and you can actually see these are all lingual tonsils. And what's nice with the Sinha Mri, you can actually use T2 weighted images, which all lymphoid tissue really lights up bright white, so you can really get an idea of how deep these and big these lingual tonsils are. So I will tell you, I find the combination of DICE and doing the MRI together, which is our protocol now. We actually, the child goes to sleep in radiology, we do the DICE, and then they immediately go to Sinha MRI. Because you may see enlarged lingual tonsils, but you're never quite sure how thick they are. The combination of the two, I think, gives the best evaluation. So, you know, there are multiple options of treatment, and this is just a diagram showing, you know, at the level of the nose, there's things you can do at the level base of tongue, at the level of the larynx. As from my previous slide, the retroglossal area is one of the most common. So, let's see. So I'm not going to go through all these surgeries, but because parents will say, well, there's nothing else you can do. No, there are multiple things you can do. Lingual tonsillectomy, if the lingual tonsils are enlarged. We can treat that tongue falling back with multiple procedures, a genoglossus suspension, hyoid suspension. We can make the tongue smaller with a midline posterior glossectomy. I do it with coblation, it's much better tolerated. And then mandibular and maxillary distraction surgery. Remember that whole midface is smaller, so the craniofacial surgery can be extremely helpful. The limitation of that is that you need to be older, okay? That whereas they will do this for like Pierre Robin babies at birth, usually they want to wait until the kids are around 17 or 18 years of age because they don't want to have to repeat it, okay? But it definitely is an option. So it's good to be have a good craniofacial surgeon that works with you in terms of treating kids with Down syndrome. Now, the other thing at Cincinnati Children's Hospital, we actually have an upper airway center. And the far majority of the children that come to this have Down syndrome because of such a high incidence of sleep apnea. And it provides a multidisciplinary approach to upper airway obstruction and sleep apnea. And it allows the families and the child to be seen by multiple specialists at one visit. And I think, you know, there's never one obvious way to treat the sleep apnea. And I think we get everybody involved with ENT, pulmonary, sleep medicine, genetics, behavioral specialists, the Down syndrome center, the plastic surgeons, orthodontics, and dentistry. I mean, it's a great way. And, you know, as you finish this is something fairly new. And as you guys finish your residency and you go to other places, this is something that you could, potentially start and really bring something to a different institution. What's newest in sleep apnea is the hypoglossal nerve stimulator. So this hypoglossal stimulator, I think of it like a pacemaker. You have a stimulator, and it stimulates the branches of the hypoglossal nerve that pull the tongue out. That pull the tongue out. You have a sensing lead sitting right next to the lung, so that as you're breathing, that's when it stimulates the tongue. And there is a multi-center study being done in the United States at this time, specifically on children with Down syndrome. And we're getting like 80% success rate. The problem, the limitation of this is you can't be overweight. And unfortunately, there's a high majority of our patients are obese. You also have to have a specific pattern of collapse. So it's, at this point, it's somewhat limited to a certain population of people with sleep apnea, but I do think it's something of the future, so it's pretty exciting. All right, let's just switch gears and talk about sinusitis, that chronic runny nose. Why do kids with Down syndrome have all this nasal congestion? Well, remember that mid-face hypoplasia, that contracted nasopharynx, the adenoid hypertrophy, nothing can drain down the back, it all comes out the front. The immature immune development, so more colds, especially the first few years. And then the sinuses are actually smaller. There's hypoplasia, the paranasal sinuses, but they more easily get obstructed. In terms of assessment, you need to rule out upper air obstruction, especially nasal obstruction. Question, risk factors, especially cigarette smoke exposure. And then, the evaluation is just like anybody else. You get x-rays, you might get CAT scans, do an immune workup, do allergy testing. I have to tell you, when I first went into practice and I'm thinking, wow, all this chronic sinus drainage, I'm going to be doing a lot of sinus surgery in kids with Down syndrome. It's very rare that I actually have to do surgery. I have found that medical management usually works extremely well. And the things that I use a lot of nasal irrigations to clear the nose. I use antihistamines. I found Zyrtec has a little bit more anticholinergic effects. So help dry up the nose. I give it at bedtime so the kids don't get tired. I use nasal steroid sprays. The antihistamine sprays can be helpful, but the kids usually don't like them because they taste really bad. I don't use Singular very often, but sometimes that is considered, and I get allergy evaluations. In terms of surgical intervention, it's just like anybody else. Adenoidectomy if the adenoids are enlarged, sinus surgery, same indications as anybody else if they need sinus surgery. The palate expansion actually helps, because remember we talked about that high arch palate decreasing the overall nasal passage size, and the palate expansion will increase the nasal airway and helps just to get some of those secretions to flow out better. And then a few things on anesthetic concerns. Most children with Down syndrome that you see, you will be doing surgery on. So you need to have a couple, some knowledge in terms of what do we need to worry about. Remember, there's cardiac abnormalities, there's a history, there can be pulmonary hypertension, thyroid disease. There is some sensitivity to drugs commonly used in anesthesia, especially cardiac sensitivity. There are some dietary supplements that a lot of the parents try to use, things like Nutravine or Paracetam, none of which have been shown to really change things, I will tell you, but a lot of the parents think that these help their children, but they can be associated with increased bleeding, so you need to ask about that. And then there's cervical spine abnormalities. Remember that 25% of children with Down syndrome will have atlantoaxial instability. And that will, what that causes that with hyperextension, hyperflexion. So we always think of don't hyperextend the neck, but actually hyperflexion is even worse. That can lead to compression of the spinal cord. Now, almost 90% of those who have it are asymptomatic. And we used to get cervical spine films on every child with Down syndrome coming to surgery, but the problem is x-rays can miss it. If you're under age 5 or 6, the bone is not calcified enough to actually get a good evaluation. It's no longer in the guidelines, the AAP guidelines to get the films. So basically, the best thing to do is just assume everyone with Down syndrome has atlantoaxial instability. and protect the neck during surgery from hyperflexion and hyperextension. So particularly like in tonsillectomy, don't use a shoulder roll, don't suspend from the Mayo stand, keep the neck in an anatomic neutral position throughout the procedure. And I will tell you, I haven't had any surgeries I haven't been able to do because of that. Subglottic stenosis, much higher incidence in Down syndrome. Children with Down syndrome have smaller subglottic and tracheal airways. So if you have a child or any patient with Down syndrome, you want to intubate with 2 sizes smaller of an endotracheal tube. So that means if you were going to put a 4.5 endotracheal tube, you should start with a 3.5 because it goes up by half sizes. Confirm there's a leak around the tube. All right, knowing this type of information has really decreased the incidence of iatrogenic, excuse me, subglottic stenosis in children with Down syndrome. And this is just a study that we did looking at the different sizes, and we controlled for both age and weight, and always found that the child with Down syndrome looking for a leak around the tube needed a smaller tube by 2 sizes, not just 1. And then there are some oral and dental anomalies that, you know, parents ask you about. They ask you, why is my child's tongue so big? Remember, it's a relative macroglossia. It's not that the tongue is so big, it's that the mouth and the oral cavity is smaller. This tongue thrusting, you see this child sticking his tongue out. It used to be that it was thought that all this tongue thrusting was a neurologic abnormality. And actually, it is probably due to sleep apnea, that there's not enough room in the airway for that enlarged tongue. And you know, when you see a child whose tongue is hanging out, that should be a sign we need to evaluate this child for sleep apnea. A lot of the children have very fissured tongues and enlarged taste buds. The parents come in very concerned about that. It's you know, it's like a geographic tongue. It's a normal, it's a normal variation, nothing to worry about. 50% will have missing teeth, so it's always good in your community to identify a dentist who has a special interest in children with Down syndrome, so that they can gain the expertise to take care of the children. And then because of that, there's a lot of problems with poor occlusion, and you need an orthodontist to help also. All right, so that's a lot of information, but I think it gives you kind of a background of things you need to know as an ENT doctor for taking care of children with Down syndrome. I will tell you, I have found it to be very rewarding. The families are very appreciative, you know, for really everything you do for their child. I think that, you know, if they see that you are an advocate for their child, that you're not just going to brush them off, that you're going to try and give them the best care that you can, they're going to be very supportive. And that's it. Any questions? I think there's only Dr. Gupta that could have a question.
That was great. I really appreciate it. We did have a couple attendees, and I'm sure more people will watch online. This was a really comprehensive thing, I think, for general folks in practice. So really appreciate it.
All right. Well, I appreciate your comments. All right. Well, hang in there and be safe, okay?
You too. Take care. Thanks.
All right. Bye-bye.